Hello and welcome back. This is ESICON 2018 Day 2 and in conversation with one of the icon to all the young endocrinologists of our country, we have Dr. Subhankar Choudhury with us. Welcome,
Hi.
sir, on board.
Good afternoon. Yeah.
Sure, talking about ESICON 2018, this time in Bhubaneswar. Along with that, sir, your association so far with ESICON, this is the 48th annual conference and we're looking forward to insightful sessions from across our faculty members, you being one of them.
Yeah. I think ESICON as it is has evolved greatly over the years. It's become bigger and in many ways it's become better as well, I must admit. I should not sound like an old timer that those were the days, it used to be so much better. And that's also because science has progressed so much, there's so much more to discuss. Over the years, however, certain changes have come across. One is, in the earlier years, there was greater involvement of the basic scientists who are non-physicians, and somehow down the line we have lost more direct links with them. So this is something I think we should try and revive and get them also on board. The other part that has taken shape over the last probably 2-3 years is also maybe focusing on cultural aspects amongst endocrinologists. And that's also a very interesting development. I think that's an area that we should further pursue and nurture for it to develop. Clearly, the science of endocrinology has evolved beyond just clinical examination to investigations in a big way. And in this context, I think the Endocrine Society of India has a responsibility to ensure that across the country, as we all know, the facilities do differ from one part to another, and there are certain centers who are doing a lot of good work in one area. So the Endocrine Society of India should try and reach out to all the endocrinologists and make the services available to all of them. Maybe a center in Kolkata is doing some good work. So the results or the benefits of that good work should be available to elsewhere. Similarly, someone doing good work in Delhi or Lucknow or Chandigarh, those should be available. And so increasingly we are now being able to offer more comprehensive, complete diagnosis to our patients. In the past that was not possible because of lack of the availability of tests. And then of course cost is a major factor that's coming in the way of more and more patients benefiting from whatever is developing in the world of science. There also maybe the Endocrine Society will have a role, the Endocrine Society of India will have a role to make available at least the investigations at a relatively low cost to those all across the country. As regards the development of endocrinology, we are having so many now new centers, so many new students coming in every year to train in endocrinology. Now, it's true that endocrinology as a discipline that gives you money is possibly not at the top. But I think endocrinology as a discipline that gives you satisfaction, that gives you intellectual boost, I think it's almost at the top. We could boast as being sort of most intellectually driven society amongst, with of course not belittling any of the other specialities. I think we are there at the top. And one of the important developments, the other important development has been the journal of Endocrinology, the Indian Journal of Endocrinology and Metabolism, of which at this point of time I'm the editor-in-chief. I'm really proud to say that today, in the past we used to struggle to get articles to be published, clearly because that wasn't an index journal, so people would rather send their articles elsewhere. But today, if we look at the figures from last year, we have had an acceptance rate of under 15%. So we have had to reject articles, which is good news for our association, for our members who are now contributing so voraciously sort of to the journal. So that's another way that we are progressing, and the future I think is really good. I do see there would be concern amongst especially the younger specialists that with so many endocrinologists coming in, how do we have enough for each one of us? I can assure you from my experience over these last several years that there's plenty enough for each one of us, so don't be worried about that. Just be sincere, be honest, and continue to read, continue to participate in meetings, continue to update yourself. That way I'm sure you as a physician will be providing great service, and I'm sure you'll be adequately sort of remunerated for your efforts.
It's a lovely keynote message, a giveaway message that you've already conveyed. However, I would like to understand and let our audience know the topics that you'd be covering through your sessions.
Right. Yesterday, actually, we had an interesting session of a mock examination for our DM, DNB trainees, which I was sort of one of the examiners there. So, which again is a good opportunity for the young budding endocrinologists to come and have a sort of dress rehearsal for the exams. And I was really impressed with the level of understanding and training that they have been receiving in different parts of this country. About the talks, well, I'll be covering two important areas. One for women, polycystic ovarian disease, a growing problem across the world, and it's more so, and especially so in our country. The other will be in males, hypogonadism. So in relation to polycystic ovarian disease, this is a common condition, one of the commonest endocrine problems in women of reproductive age group, apart from diabetes and thyroid disorders, and an area where maybe there is some sort of tussle, if I may say so, as to who should be treating them. Gynecologists have traditionally handled polycystic ovarian disease, women and young ladies, but increasingly I think it is basically an endocrinologist domain, but it has, as we all know, different facets, different areas. For example, an endocrinologist will not be able to offer the entire range of services. Similarly, for example, diabetes. We are the ones who are primarily entrusted to with treating diabetes, but of course that person with diabetes will need a cataract extraction, for which we have to send to an eye specialist, will need a stent placement, for which he or she will have to go to a cardiologist. Similarly, the polycystic ovarian disease, there will be a certain who will require maybe laser epilation, removal of hair, for which we have to send to a dermatologist or cosmetologist. They would have infertility, which is not amenable to simple medical treatment, may require artificial reproduction techniques, for which we have to send to the gynecologist. But basically it should be at least the team treating someone with polycystic ovarian disease, I feel should be headed by an endocrinologist. And our understanding of polycystic ovarian disease has also evolved significantly. We do understand there is a significant component of insulin resistance. We also now are beginning to understand what are the long-term consequences of having polycystic ovarian disease beyond the immediate reproductive concerns of of infertility, of irregular periods, and also of cosmetic concerns. For example, the issues of later development of type 2 diabetes, increased risks of coronary artery disease, and increased risks of endometrial cancers. So when we treat someone with polycystic ovarian disease, I think while we need to address the immediate concern that has brought the girl, the young woman, to the physician, but we also need to make her aware of the broader issues at stake, and we should try and address them as well as possible. Moving over to the other issue of hypogonadism in males, this is not as common as polycystic ovarian disease in women. Nonetheless, is a very important issue, and also an area which has been under discussion for the last several years, especially the concept of andropause, which is supposed to be something akin to, but not exactly the same as, menopause in women. While that is still a relatively controversial issue as to whether most aging males should be having a replacement of or being treated with testosterone, but clearly those who are clearly hypogonadal, and we have now definitions, biochemical definitions, and especially if they have symptoms, we do have several preparations to treat them. It's not just the injectables, we now also have the gel preparation, and we can offer them a very good quality of life, and hopefully it will also translate into advantages, big advantages, not as just immediate addressal of the symptoms, but also maybe hopefully reduction of fractures, and maybe also, that's the other big controversial area in relation to cardiovascular protection. There are studies which suggest maybe these androgens may protect the cardiovascular system. There are other studies which raise concerns that it may be harmful. So that's an area that we are still sort of watching keenly, the evolving field, and maybe we'll have a better answer soon. So it's exciting days ahead in this conference, and exciting years ahead for us as endocrinologists.
Thank you so much, Dr. Choudhury, for sharing your concerns and so much of information in this conversation that we have just had.